here, that is Ankit 20, right? For getting some extra discount over here. Okay, let us see more over here. So after this, just a second. Okay, yeah. So these are the core features of the Auricle. As we can see here, we have live classes like this. We also get the recorded classes, notes, and MCQs. And subscription plans we have from basic, from standard to mentorship. We have like this 3-month plan to 12-month, and all the features and the prices are given over here. In the mentorship, that is for the 1 year, you get extra live doubt clarification, one-to-one personal guidance, apart from pre-recorded classes, live classes, notes, as well as the examination module. Okay, so also don't forget to book your slot for personalized counseling session as well. And there's a code below written, this Ankit 20 over here, right? You can use that also for your discounts on the subscriptions. Fair enough. Let's start the session over here. And here we come now to the part of the leg region, right? So we are done with the our thigh region. Then you come to the leg and the foot. And finally, we'll talk of the joints and other features over here, right? These two things are what we are going to cover. Okay. So in the leg, so leg we discussed, and leg we have how many compartments? Leg again we have 3 compartments. So those 3 compartments in the leg are, just to begin before going into all these tables and all. Okay, just an empty over here. Yeah. So leg has how many compartments? Leg has 3 compartments. It has an anterior compartment. This anterior compartment also known as the extensor compartment. Okay. Then it will have a lateral compartment. This lateral is also known as the peroneal compartment. Then the thickest one over here is a posterior compartment. It has been also known as the flexor compartment. Remember these 2-3 basic points. Now the anterior or the extensor compartment, the nerve supplying it is a deep peroneal nerve. Which nerve? A deep peroneal nerve. The nerve supplying the lateral or the peroneal is the superficial peroneal nerve. Superficial peroneal nerve, and both of them are branches of common peroneal nerve. Now, why I'm telling you over here again, try to understand that this nerve is the most common injured nerve in the lower limb. Reason being that it winds around the head of fibula. It is very close to the head of fibula. So basically, you can say it is subcutaneous against a bone. That too on the outer aspect of the knee region, right? That the fibula is a lateral bone. So therefore, any injury happening from the outside can injure this nerve. Now, if this nerve is injured, you can very well understand that if this nerve is injured, it will lead to injury to both of these deep peroneal and superficial peroneal. These muscles will go into these muscles and this area, they go into their paralysis. Coming to the posterior or the flexor compartment over here. Now, posterior flexor compartment, the nerve supplying this is the tibial nerve. Remember, we discussed last time about the sciatic nerve. Let me just give you an outline again. This was the thick sciatic nerve. Then it divided into a tibial and a common peroneal nerve, right? Remember, this was a thick sciatic divided into a tibial nerve that went down straight down posteriorly. So it is supplying the posterior compartment. And the lateral one over here was common peroneal nerve. Now it will again divide into 2 nerves, which are your deep peroneal and superficial peroneal nerves. This is how the thing goes over here. Do also remember that this posterior compartment is the thickest compartment because the muscles over here are basically anti-gravity muscles. And the posterior compartment is so thick that inside this posterior compartment, we have 2 other compartments which are deep and superficial. So in your calf area, the muscles which you normally feel, those are the superficial muscles like the gastrocnemius and the soleus. The deep muscles are the flexor muscles, which will flex the toes, which are going to flex the toes. So entire muscles in the posterior compartment of leg are supplied to tibial. Because there's an outline, this we should know, right? Similarly, vessels are also different, but there's an outline. So just to complete and repeat it, guys, once more, leg has 3 compartments: anterior, lateral, and posterior. Anterior is the extensible. This is the leg over here, right? This is the foot over here. So anterior muscles are the extensor muscles. So when they contract, they will extend the foot. This is the extension of the foot. The extension of the foot, because students get confused, the extension of the foot is also known as the dorsiflexion. Is also known as the dorsiflexion. Okay, dorsiflexion is same as extension of the foot. Dorsiflexion is also known as extension of the foot. Then lateral, we have this lateral part over here, the peroneal part. They will evert the foot. This is lateral part of the foot going like this, that is eversion of the foot. Okay. And finally, we have this posterior or the flexor compartment. They will actually flex the foot and the toes. So actual flexion is your plantar flexion. Actual flexion is the plantar flexion, and dorsiflexion is nothing but dorsiflexion is your simple as extension. The dorsiflexion is extension, and plantar flexion is the actual flexion. Do remember this basic confusing points. Now let us come back. So front, lateral, and medial side of leg and dorsal foot is the total, we can say, the name of the topics which we are going to cover up. Okay. Peroneus longus is simple. The peroneus longus is a muscle, is one of the two muscles of the lateral compartment of the leg. Lateral compartment has two muscles, peroneus longus and peroneus brevis only. Okay. Now, apart from this, this can come as a question. Now, apart from this, now muscles of the anterior compartment of leg. Anterior compartment, as I previously discuss, are mainly extensors. So now look at the muscles. Tibialis anterior will be a muscle. You might say, it is not an extensor. See, there are two tibialis anterior and tibialis posterior. There are two tibialis muscles, tibialis anterior, tibialis posterior. Both of their job is doing inversion of foot. We'll see later on. The inversion. Inversion is sole of the foot faces medially. Imagine this is the right foot over here. This is inversion. That is eversion. Eversion is done by the peroneus longus and brevis. Inversion is done by the your tibialis anterior and tibialis posterior muscles. So tibialis anterior over here in the anterior compartment. Then you have extensor digitorum. Okay. You have peroneus tertius as well. Do remember this is peroneus tertius. Then you have one more extensor, that is extensor hallucis longus. These are the muscles of the anterior compartment of the leg. These are muscles of the anterior compartment of the leg. Tibialis anterior. These are four muscles. Let me number them so that there is no confusion. Tibialis anterior, extensor digitorum longus, peroneus tertius, extensor hallucis longus. Now coming to the other two muscles which are shown over here, but these muscles over here, they are the muscles of the lateral compartment of leg, not the anterior compartment. The two muscles, peroneus longus and peroneus brevis over here. Okay. Table is very important. Okay. If you want, you can take a screenshot of this table and just read it once. Now, just to complement what we discussed a while back about the nerve supply, as we said that all the anterior leg muscles supplied by which nerve? Deep peroneal. Therefore, here you see all them supplied by deep. Lateral compartment we said supplied a superficial peroneal nerve. Have a look over there. Superficial and superficial. Okay. Now, these are the muscles shown over here. So, like we studied in the upper limb, that there are flexor and extensor retinaculum. Similarly, over here in the foot also, we will have extensor and flexor retinacula. As there are three compartments, so in the foot we will have, or not particularly foot, but ankle, we will have three sort of retinacula. One which we can see anteriorly over here, this all is the extensor retinacula. This is E dot R dot. One which is found medially over here is the flexor retinacula. And one that is found laterally behind the lateral malleolus, that will be the peroneal retinacula. Okay, so three compartment of muscles and three sort of retinacula over here. You can see all these muscles going down, and they are, once they contract, they will do which flexion? But so you have said extension, yes. Extension also known as dorsiflexion. Also known as dorsiflexion, right? So remember the image, and you can draw this image. This will actually be helpful. Now, as in the thigh, so in the leg also, these TS, transverse section, are very important for understanding. Let me just tell you about this TS over here. Now look at this TS. Okay, you are seeing two bones over here. This is the smaller bone, that is F for fibula, that is the T for tibia. So this is the medial side, that is the lateral side that we know. Okay. Now look over here. If I highlight this with, say, this green color, these are the compartment which you will see over here. They are which compartment? They are the anterior compartment muscles. So you have tibialis anterior, extensor muscles, and the artery and the nerve over here also you can see. The artery is a tibial artery, nerve is deep fibular or the deep peroneal nerve. Nerve is the deep fibular or a deep peroneal nerve, artery is anterior tibial artery. This much is the anterior compartment. Now have a look at the lateral compartment, also very small. Only this much is the lateral compartment. Having only two muscles, which are your peroneus longus, and you have the peroneus brevis over here, right? Peroneus longus and peroneus brevis. The nerve is superficial peroneal, and the artery will be a fibular artery, branch of posterior tibial artery. Now compare all of both of these compartments with the posterior compartment. Let me show you the posterior compartment with this color over here. This hole is a posterior compartment. You can see how the difference in the area of the volume of the posterior compartment. And in the posterior compartment, you can see the septum over here that is known as transverse intramuscular septum. That is known as transverse intramuscular septum. It divides the posterior compartment into a deep group and a superficial group. But luckily, all of them are supplied by which nerve? The nerve over here is the tibial nerve. The nerve over here is the tibial nerve. So all of them supplied by the tibial nerve. Now you might wonder this, why is it is so huge? The reason being that this posterior compartment actually helps in walking, push off movement during walking. Therefore, they are regarded as the anti-gravity muscles. They are lifting or they are moving your body against the gravity. So their size normally increases. Okay. The muscles over here, as we can see, we'll see later on also, you have the gastrocnemius and soleus where in the superficial compartment. As you go deep, you will find flexor muscles over here, and also tibialis posterior muscle over here. They are the deeper muscles. Some muscles are not shown over here, like for example, we'll see later on, but a muscle like popliteus, because it is present at the region of the popliteal fossa. So it is not seen in this TS. So just see the difference between the volume of the three compartments. Okay, now another question that might arise is the dorsalis pedis artery. Before going to this artery, let me actually revise our artery. In the arteries that we discussed in the previous session, we said, okay, we have the external iliac artery that continued as the femoral artery that went down, and it went then posteriorly as the which artery? Popliteal artery. Then popliteal artery gave off a anterior tibial artery, and it continues as the posterior tibial artery. Okay, I'll just label it later on, don't worry. This posterior tibial artery will actually continue as the plantar artery, and this anterior tibial artery will continue down as the dorsalis pedis artery. Now let me label it for your understanding. At the top, we had the external iliac artery, whose name changed to femoral artery. Then this femoral artery went through the adductor canal. This, imagine, is the adductor, the ADD adductor or the Hunterian canal. Then this dots mean it went posteriorly, became popliteal artery, popliteal fossa. Then popliteal artery divides into an anterior tibial, so it again came anteriorly, so it is in solid lines. And this being the posterior tibial artery. Posterior tibial artery. Posterior tibial artery actually will go along with the flexor muscle tendons, like for example, flexor hallucis longus, flexor digitorum longus, and it becomes the plantar arteries. Plantar arteries will have two, medial and lateral. In the meanwhile, let me add one more artery over here. This posterior tibial will give off one more artery that is known as fibular artery. It supplies the lateral compartment of the foot. Fibular artery. And this anterior tibial over here, will continue down as the dorsalis pedis. See, the name is dorsalis pedis. I am on the dorsal side of foot. So if you look at the upper surface or superior surface of the foot, that is the region of dorsalis pedis artery. This is a whole simplified version. Now let us see what we can take out from here. Dorsalis pedis artery is the artery of the foot, palpable at the dorsum of the foot. Origin, it is a continuation of anterior tibial artery. Here is the anterior tibial, here is the dorsalis pedis artery. It begins between the two malleoli and then passes along the surface of the foot, reaches the first metatarsal space, dips down between the dorsal and interosseous muscles, because it has to complete the plantar arterial arch. Remember, in hand and palm, we studied about the two arches. There was a superficial and there was a deep palmar arch. Similarly, in the foot also, we have a plantar arterial arch, and that is completed by the your dorsalis pedis artery from the superior surface. Okay, the dorsalis pedis artery also, do remember, learn to palpate it. Where could you palpate? See, if you look over here in this image over here, you ask the patient to extend the great toe. Once the patient extends the great toe, let me enlarge this image over here. You can see this tendon over here, that is the extensor hallucis longus tendon. And you can see these toes also, they have some tendons which are known as extensor digitorum longus tendon. So if you palpate between the extensor hallucis and the extensor digitorum, somewhat over here will be the location of the dorsalis pedis artery. Now this is very important for palpating. What is the reason? Reason is suppose you can see this whole arterial tree which I which I tried to make over here. Just a second. Yeah, this whole arterial tree, if you look over here, Now, if in a patient you are able to palpate the dorsalis pedis artery, it means that the anterior tibial artery is patent, the popliteal artery is patent, the femoral artery is also patent. If you can palpate the dorsalis pedis artery, and if you can palpate this posterior tibial artery also, that can also be palpated where? At the region of flexor retinaculum. If these two arteries you can palpate, you need not need to palpate the femoral popliteal, because already the distal vessels are easily palpable. It means the blood proximally is fine. The blood traveling in the proximal vessels is okay. Okay, this gives us a good idea. So palpating these arteries are very important, because peripheral vascular diseases in lower limb are also quite common. That is why this topic is important, right? So this is a dorsalis pedis artery here, and the image over here showing you all these images. Relations of dorsalis artery, you can just go through it. There's no problem. Superficial, what do you see? Superficial, you see a skin, fascia, and some retinaculum and extensor hallucis brevis muscle. Okay, brevis is not longer, it is brevis muscle. And deep, you have the capsules, you have the bones which lie deep. Medially, if you remember, medially we said it is lying between extensor hallucis longus and extensor digital longus tendon. So this artery is actually running between these two structures. Medially, you have the extensor hallucis, and laterally you have the extensor digital longus tendon. Therefore, you ask the patient to extend the great toe, then you can easily reach the artery. Branches of dorsalis pedis artery, branches of what? Of dorsalis pedis artery. You can remember the branches, lateral tarsal, medial tarsal branches, you can easily, see the artery has to give up branches, no? Because the foot is a big area and one vessel is coming, obviously, one vessel, where can just one vessel has to go everywhere, no? So it gives up branches. So you can supply the whole area. Other branches, you can remember the important branches over here will be this arcuate artery as well. Arcuate means it forms an arc. It forms an arc. Like, for example, if you see this over here, this is the arcuate artery. These are the tarsal arteries. This arcuate. This arcuate artery will then give up branches that will go and supply the dorsum of the foot. Therefore, that arcuate artery is important. Okay. It ends by anastomosing with the lateral tarsal and branches. Lincoln anatomy, initially I already told that the pulsation of this artery is important. Is important. Okay. It might be absent in very few people. That doesn't mean much, because see, when you're palpating artery, there are normal anatomical variations which are quite common. What we normally study in our books is actually the mean of all the findings that we have seen in human beings, as many cadaver dissections have been done. But some anatomical variations are always there. Don't be frightened by it. If suppose some person you are not able to palpate the dorsal pedis artery, no big deal. There can be some small anatomical variation. The point over here is that the person's foot should be warm, should not be cold. There shouldn't be any necrosis. There shouldn't be any pain. Therefore, in medicine, we read about all the history and examination and different things, not just okay, palpating the artery or not. But still, you should know how to palpate the dorsalis pedis artery. Okay, let us see a question. An athlete runs for 3 kilometers every day. He developed severe pain above his ankles after 4 days and could not run. Okay, there can be a vascular disease over here. So there can be vascular disease over here. Anterior tibial compartment syndrome. Okay, this is due to the vessels which are in the anterior tibial. They may be sometimes damaged also. Okay, name the muscle present in the dorsum of the foot. Let us see. Soleus is present where? Soleus is present where? In the posterior part of the leg. Extensor digitum. Yes, this is present in the dorsum of the foot. So the name itself is extensor. These two are present where? Peroneus brevis is present laterally. Okay, even peroneus tertius is present in dorsum, but that goes laterally. So in fact, both B and D are not wrong, but looks better than D. Okay, B looks a bit better than D over here. Saphenous nerve is a branch of which nerve that we have discussed in detail. That remember, if we did a mnemonic also, PQS, posterior division of femoral nerve supplies your quadriceps muscle and gives off saphenous nerve. I repeat again, posterior division. P is for posterior division of femoral nerve. PQS, Q was supplies all the four muscles of quadriceps femoris. And this continues as S was one of the cutaneous nerve, that was a saphenous. It is definitely a branch from the femoral, that to a posterior division of femoral, as is written over here. Okay. Medial plantar nerve supplies. A medial plantar nerve is similar to median nerve in the hand. It supplies medial 3.5 toes. Okay, middle 3.5 toes. The structure passing the under the cover of superior extensor retinaculum is. Okay, so there are various structures that will pass under the cover of superior. So some structure pass through superior, some structure pass through inferior. Okay, only few will pass through both. Structure passing the cover of superior extensor retinaculum will obviously be the structure which are lying in the anterior compartment of leg that includes all of these three. So answer, yes, this answer is D. Okay. Okay, so it is your BAAD. Remember here, in case of peroneus tertius, peroneus longus would have been a better option. Else B and D, you guys might be confused, right? Okay. Moving on to the back of leg now. So we have seen the anterior lateral part of the leg, and now let's see the back of the leg. The back or posterior compartment of the leg, as we see, what in already information we have if we revise. Posterior leg, okay, it's a huge compartment having deep superficial parts. Nerve is tibial nerve, artery is your posterior tibial artery, right? What do they do? The muscles over here helps in walking. So they will do what? They will flex the ankle joint, and they are going to flex the toes as well. That's the main major part. Okay. Out of them, do remember the tibialis muscle over there, the tibialis muscle. In the posterior, we have tibialis posterior. They do inversion. So inversion is a common function of not just tibialis posterior, but in fact also tibialis anterior. So inversion is done by both of these muscles. Inversion of foot. Okay. This is information we know before going into the notes and all. This is what at least the minimum basic requirement, right? So back of the leg is calf, right? Posterior compartment is into three parts: superficial, middle, and by two facial septa, superficial and deep transfer, right? So they can say it is three part, but compartment wise, there are only two compartments over there. Superficial fascia of the leg has no veins over here. Now, as we discussed, I guess earlier on, we have also discussed that in lower limb, what will happen? Know that the blood, arterial blood can easily come down because it is going with the gravity. But the problem occurs in the venous drainage. Blood has to go against the gravity. Therefore, venous problems are quite common in the lower limb. Also, like in upper limb, venous pathologies are less common. But in the lower limb, the venous pathologies are more common. These two veins over here, the names are written, they are both superficial veins. The superficial fascia, they've written, no, they are both what? They are both superficial veins. That is, they are close to the skin. The small or short saphenous vein, it lies laterally. The great or long saphenous vein, it is the longest superficial vein, and that lies medially. That lies medially. Okay, it is the longest. Why? Because it drains where it drains into the femoral vein. I guess that we have done a bit in the saphenofemoral opening also in the beginning of the lower limb. Now, extra topics they are written, nerve and branches of. So remember these few things over here. Let me just highlight. Saphenous nerve is important. They can ask you it's a branch of what? Medial cutaneous nerve of thigh. Okay. Then you have posterior cutaneous nerve of thigh. Okay. Then you have sural nerve, and you have the lateral cutaneous nerve of calf. Okay. So see over here. Sural nerve is normally a branch of both of these nerves. Okay. Lateral cutaneous nerve of calf can come from the tibial nerve. This posterior cutaneous nerve of thigh, it comes from the sacral plexus. Okay, and this posterior division, they can also come from the plexus. Okay, remember these dermatomes over here. Out of these, this foot over here, this is important more. And I'll tell you the questions from where the questions do come. Why? See, because diseases like the most common chronic conditions in India or also in different areas of the world, we have the diabetes mellitus type 2, right? DM type 2 is quite common. And in that, one of the complications is peripheral neuropathy. One of the complications is peripheral neuropathy, right? It starts from the foot area. We have small fibers, we have large fibers that might be affected. So you should know sensory wise that medial 3.5 toes are supplied, innervated by this medial plantar nerve. Lateral 1.5 toes by lateral plantar. Sural goes to the lateral border, saphenous goes to the medial border. This basic we should know. And if you remember, I told you this about saphenous nerve, a bit of information while discussing the femoral nerve. It is the longest cutaneous nerve. And at that time, I told that, okay, it reaches up till the medial border of foot and the ball of big toe. And here is the proof of that. Saphenous nerve is coming from the femoral nerve that lies where at the lateral part of the, you can say the femoral triangle. From there, saphenous nerve rises and it reaches up till here, to the whole entire length of the lower limb. Okay, this is important. And the question that might come over here is, look at the area supplied by superficial peroneal nerve, the cutaneous area. So whenever there is CPN nerve damage, CPN nerve damage, where in the around the neck of fibula. So the CPN divides into superficial and deep peroneal. So if CPN is totally damaged, SPN will also be damaged. Therefore, there will be sensory loss in the dorsum of the foot and also in the upper areas. But if suppose only DPN is damaged, suppose only DPN is damaged, then what will happen? This area, you can see this blue area over here, first web space. That has come as a question. This DPN motor supply, as we all know, is to the anterior leg muscles. There is no doubt about it. But its sensory supply is very much limited to the first web space. To the first web. First web space is between the great toe and the second toe. So this is the great toe is the first toe, there's the second toe, the third, fourth, and fifth toe over here. So DPN sensory is still the first web space. That is very important to remember. Okay, let us see over here. Superficial veins, okay, deep fascia over here. Now again, if you look at the leg, there is deep fascia is quite rampant over here. And if there is any, say, bone fracture, or if there is any arterial bleed, listen carefully, if there is any arterial bleed, or if there is collection of fluid, if there is any collection of fluid, by fluid I mean apart from blood, other fluid also. Blood is there, hematoma can develop. Now see, in the lower limb and in the upper limb, there's quite a thick deep fascia. So there is no room for expansion. When there's no room for expansion, and suppose there is bleeding from the vessel, where will the blood go? Blood will go into the compartment. So what will happen is, as the blood will try to expand the compartment and that compartment cannot expand, whatever structures are there, the nerves, the arteries, the veins, they start to be compressed. That is known as what? That is known as compartment syndrome. And it is quite a painful syndrome. The only thing that as a doctor you can do is, you can do fasciotomy. Just take your scissors, scalpel, and cut through the skin and superficial deep fascia, open it, where the fluid can come out. Whatever collection fluid is there, it can come out. Okay, so decrease the pressure. Compartment syndrome is there. It's a clinical diagnosis. So the posterior compartment of leg is bounded. I just told you an applied part. Do remember it. So now the posterior compartment of the leg is bounded and subdivided by deep fascia. Okay, boundaries of posterior compartment are boundaries are there. Okay, fine. Flexor retinaculum. Now, where will the flexor retinaculum be? Let's understand this. Now, understand that posterior compartment. Suppose I try to make you can imagine that if you look medially, right? So this will be the fibula bone. Just imagine like this, right? And covering it medially, because we are seeing medially, big one, that will be the tibia bone. This will be which bone? Tibia. So tibia is overlapping which bone? Fibula. This is anterior, that is posterior. Tibia is medially, fibula is laterally. What I'm trying to make over here is, you have a lot of muscles over here, right? A lot of muscles over here, right? What they're going to do is, they are all going to come down, and then the tendons and few muscles will end at the calcaneum, forming the tendo Achilles. Other tendons will go to the foot. Try to understand. This will be the Achilles tendon, so that will insert into which bone? It will go to the calcaneus. But the tendons over here, these are all the flexor tendons. They are going to flex the toes. Now, due to which this area over here, you have what? You have the flexor retinaculum. Okay, let me use a different color. Yes, this is better. This will be the flexor retinaculum. Extensor retinaculum was where? Extensor retinaculum is, if you keep on looking at this will be the anterior leg muscles. Then tendons goes over here, and imagine here what? Here you have the bones of foot. Imagine, I'm just trying to make these are imagine the foot bones, the bones of foot. So the extensor muscle tendons will go over here. And this is the place where we will have the extensor retinaculum. So this is the place where we have the extensor ER is extensor retinaculum. I hope this point is clear for understanding, right? Now look at the flexor retinaculum. Give the attachments and all that is anatomical perspective, but yes. So the lower part of the deep surface gives origin to the greater part of the adductor hallucis. Yes, the one muscle that comes from the flexor retinaculum, abductor hallucis. It is pierced by medial calcaneal vessels and nerves. Attachments, please understand the attachments are important. Anteriorly, it is attached to the medial malleolus and goes behind till the calcaneus. So you can see over here that this flexor retinaculum is running from medial malleolus behind till calcaneus, and it is binding the tendons. And with the tendons, what else is bounded by it? With the tendons, you have the posterior tibial artery dividing into plantar arteries. Then also you have what? You have the tibial nerve dividing into medial lateral plantar nerves. So along with the tendons, it also have vessels and nerves and also lymphatic, obviously. Okay. Structures passing deep to flexor retinaculum. Here we can have a look at it. What are the structures that pass deep to the retinaculum? So tendons are passing. Okay. Nerve and artery share a common compartment. Tendons have a separate compartment. Fair enough. Tarsal tunnel. Tarsals and a tunnel over here. The structure passing deep to retinaculum, medial to lateral side. So structures passing deep to retinaculum from medial to the lateral side are. Remember, the direction over here is medial to lateral. Okay. The doctors are not hallucinators, was a mnemonic. Now a new mnemonic has come out over here, as we can see over here. Tina deserves a nice husband. Okay. Before we used to, when we were students, we used to remember it by the doctors are not hallucinators. So it doesn't make any sort of much meaning. But Tina deserves a nice husband. That is also a mnemonic that actually sort of makes a sense. And good luck to Tina, right? So can you remember this mnemonic? Tina deserves a nice husband. T is for tibialis anterior. Deserves is D is for digitorum longus. A nice is artery and nerve. A nice is artery, A for artery and N for nerve. Husband H is the flexor hallucis longus. This you can remember, right? Tina deserves a nice husband. That's good, right? You can remember like this over here, and all these images are. So now coming to the posterior compartment leg muscles per se, so we have two compartments, superficial and deep muscles in the posterior compartment. And superficial, I told you have gastrocnemius soleus and also a small plantaris. Plantaris is a very thin muscle, not as muscle. Basically, it's most of the plantaris is a tendon, and that runs along with the lateral head of gastrocnemius. It runs along with the lateral head of gastrocnemius. Now, per se, the action of plantar is not that much because muscle mass is very less, muscle belly is very less. Majority of the muscle is tendon. Okay, therefore, this is therefore used in a lot of grafts as well. Okay, deep muscles, you have this all this flexors, and this popliteus. I told popliteus why, because it was not seen that TS. The reason being that popliteus is a small muscle located in the upper part of the posterior compartment of leg, close to the popliteal fossa. In fact, this muscle goes inside the capsule of the knee joint. Okay, so here you have the muscles. In muscles, I already told origin, insertion, innervation, action are important. Blood supply, you may or may not remember. So you have gastrocnemius aspects, you have soleus aspects, you have plantaris aspects. You can take a screenshot if you want to. But yeah, understand that all of these muscles, gastrocnemius, soleus, and plantaris, they are superficial muscles. They don't go to the toes. They reach where they reach the calcaneus, right? And via which tendon over here they form? We all must be aware of Achilles tendon. Achilles tendon or tendoachilles, whatever you want to call it as. And again, a very important clinical part. This tendon, Achilles tendon, you can easily see it, feel it, right? At the posterior part of your ankle, that huge tendon is the Achilles tendon. This tendon is sometimes ruptured in mid-age or middle-aged men. Normally, it is seen in middle-aged man. It is sometimes ruptured. When middle-aged men, they again start to exercise and do any activity like play any sports where you involve a lot of jumping and running. This tendon might get ruptured in 40s or 50s. It might happen. Okay, maybe in early 30s also. Athletes also commonly get ruptured. Like for example, if I do remember, recent news was there about our Indian cricket team bowler Mohammad Shami. Mohammad Shami. He had this tendon, Achilles tendon rupture, I guess, a month or a couple of months back. It actually happened, right? So yes, this can be ruptured. Now these are all the images over here, and this is the calcaneal tendon that we are actually discussing. Tendo Achilles. You have your gastrocnemius, soleus, and plantaris over here. These are three muscles that combine to it, the nerve and everything. A small saphenous vein, a quick word of it too before it gets missed out. A small saphenous vein is a superficial vein present laterally, and it starts at the lateral around the lateral malleolus over here. It actually starts from the dorsal venous arch, then it goes behind the lateral malleolus, and then it ascends up, and finally it drains into popliteal vein. Therefore, in this image, the popliteal vein is shown, and you can see, so we can trace this small saphenous vein where it is going, and so you realize it enters into the popliteal vein over here. Great saphenous vein went till the upper part of the thigh near the femoral triangle, the base of femoral triangle, at the saphenofemoral locus. So that is quite a long vein compared to the small saphenous. Okay, now let us look at the deep muscles. Deep muscles, basically we have three, four muscles, one including popliteus. Okay, popliteus is the muscle which lies inside, or its tendon lies inside the capsule of the knee joint. So it is the only intracapsular tendon. Remember that too. Only intracapsular tendon in the entire lower limb. Only intracapsular tendon in lower limbs. Similarly, if there's someone asks you about the upper limb, the only intracapsular tendon in upper limb will be which tendon? Think about it. It's going to be your any rotator cuff muscle or some other muscle. It is some other. It is a long head of biceps brachii. It is a long head of biceps brachii muscle. And due to which, remember, there was a groove known as bicipital groove between your greater and lesser tubercles of the humerus. There's groove known as bicipital groove. This is the tendon that actually runs in that groove. The name is being derived from here only. Bicipital groove means a groove for the long head of biceps. Okay, right? Here we have this deep muscles. You see their names again, origin, insertion, and all. Nerve supply, no, needless to say, you can see everywhere it's a tibial nerve. Even if you look at the superficial, these gastrocnemius soleus, again, it is tibial nerve. So tibial nerve, by without any doubt, supplying all of these 7 muscles. Okay, you can make an image over here, diagram also. You can see all these flexor muscles. Where are they all going? Just try to see over here. They are going behind the medial malleolus through the or deep to the flexor retinaculum. While looking on the lateral side, you can see the peroneus longus and peroneus brevis. Here you have the peroneal retinaculum. Peroneal retinaculum for these 2 tendons over here. And tail we have the extensor retinaculum. Okay. Yeah, I hope this is clear now. So we have done this compartment. Let us see a artery over here, posterior artery. Posterior artery, if you remember, we discussed that the popliteal artery. The popliteal artery can actually palpate it in the popliteal fossa, though you need a deep palpation for it. But in the popliteal fossa, the popliteal artery divides into anterior and posterior artery. So it is a branch of popliteal artery, as the first line is over here. It supplies the posterior compartment of leg and sole of foot. So in the posterior compartment of leg, we'll call it as the posterior artery, but in the sole of foot, it actually divides into plantar arteries. Plantar arteries, both of them are medial and lateral plantar artery. Begins where? Begins, you can see over at the lower order of popliteus between tibia and fibula, passes deep to tendons arch of soleus to enter the back of leg, runs downward slightly medially, and then terminates deep to flexor retinaculum, divides into these 2 medial lateral plantar arteries to supply the sole of foot. That is the whole point of it. Okay. Relations, visual relations, upper lower third ankle. You might see them if you wish to. Not frequently asked about this artery. This artery is accompanied by 2 venae comitatus and by the tibial node. Explain about the branches. Okay, largest branch of posterior artery. Okay, posterior artery. Then muscular branches supply the muscular branches as well. Nutant artery. Now this nutant artery also sometimes have question has come. The nutant artery tibia is the largest nutant artery in the body. Nutant artery, if you remember our first lecture on the general anatomy, we discussed the bone part. In bone, we discussed the direction of nutant artery is opposite to the direction of the growing end of the bones. To the elbow I go, from the knee I flee. Remember that milking cow position thing. So those are the direction of nutrient artery. In the entire body, the largest nutrient branch is that which goes to the tibia, and that is a branch of posterior artery. Then you have few anastomotic branches, anastomos at the mainly around the, you can say, the ankle and some around the knee area as well. Terminal branches we have seen already. Okay, here is the image of the artery. Do remember over here that this posterior artery supply the posterior compartment, no doubt about it. But this in fact also gives the fibular artery which supplies the lateral compartment of legs. Some you might be, if you are wondering who supplies the anterior compartment, it is the anterior artery. Now this question has been asked in your MCQ exams also. Even they have given a arteriogram of the lower limb, arteriogram of the lower limb, and the popliteal artery was given, if I remember the question, and divided into 2 arteries, and then there was an artery coming out of the posterior artery. They asked about the artery. Basically, they asked about the fibular artery. Okay. So if you know that this artery is coming from that particular branch, you can actually try to see it. Right? Now, where to palpate the posterior artery? Very easily palpated just behind the medial malleolus. So if you can palpate this artery and if you can palpate the dorsalis pedis, you are sure that okay, the arterial tree of the lower limb of that particular lower limb is going fine. So this is where the posterior artery is palpated behind the medial malleolus. And if I just tell over here one point, so that maybe over here also, this is the medial malleolus running in front of medial malleolus, this vein over here, superficial vein, this is going to be the great saphenous vein. It is very helpful in venous cut open also. Suppose a patient comes in emergency trauma, the shock and lower BP and is going crashing out, the patient is crashing out. You're looking for the veins in the upper limb and other areas and not able to find the vein. This is the area where you can do a venous cut open. This is an area where you can do a venous cut open because the medial malleolus is a bone. It is the lower end of tibia. So just cut open this part and you search the vein. The vein you will find over there, that will be the great saphenous vein. That is also important in saving lives as well. This you should know in front of medial malleolus. Now, clinical anatomy, let us see what clinical anatomy are we introduced over here. Posterior pulse can felt. In case it is not felt, then can be claudication. You can patient will give a history. Then when I start to walk, after say 10 minutes, my leg starts to hurt. My leg starts to pain. When I sit for a few minutes, again the pain disappears. Again I start to walk. Again pain may start. So that sort of history can be given. Peroneal artery is same as your fibular artery. It is a branch of the posterior tibial artery. Because posterior tibial artery will also give peroneal artery. Supplies the lateral compartment, begins where over below the popliteus, runs obliquely, descends down, passes behind inferior to tibiofibular ankle joint, terminates by dividing a number of lateral calcaneal branches. Branches of peroneal artery are muscular branches, nutrient artery to fibula, not to tibia but to fibula, and a lot of anastomotic branches over here. It's a complex diagram, but here you can trace few arteries. If you wish, you can trace few arteries. Let's try to trace few arteries. Look at the peroneal artery, look at the antitibial, and look at the posterior tibial first of all. And look around the ankle, how many anastomosis are they giving? This is which view? This we are looking at a lateral view. Why? Because we are looking at a peroneal artery. If this was a medial view, we would have seen, we would not have, be able to see the peroneal artery. So if you're looking at a peroneal artery, you're looking at a lateral view, right? Antitibial and posterior and all these anastomotic branches over here. You just see, there's not much complicated. Even if you know, okay, this is dorsalis pedis artery, you should know, okay, what are branches they are giving. Then you should know the terminal branches of the posterior and fibular artery and make some anastomosis around the ankle area. Okay. Okay, an elderly man complained of pain in the inner aspect of right ankle joint. Pain was also felt in the area of sole and his on walking could be an artery problem. Which muscle is called the peripheral heart? Okay, so which muscle is that? That is probably our soleus muscle because the reason is there are a lot of veins which are or vena comitatus located around the soleus muscle. So whenever we walk, the soleus muscle contracts and the veins are drained. Therefore, it is said that don't sit too long. Don't sit for too long. It is already bad for your back and other areas of the body. But mainly, the patient might develop a deep vein thrombosis. If you're sitting for too long, suppose you have a long flight, try to stand and walk a bit. If not, then at least move your ankle so that your muscles contract and the blood is drained from the lower limb. Else, if the blood stagnates at the lower limb, around the ankle or the leg, they might develop thrombus. There could be deep vein thrombosis, and if it is dislodged, it may lead to pulmonary embolism. And not, I'm not no, exaggerating the things, but a death can occur from it. Even death can occur. Okay. Out of the following muscles, which muscle acts as a locked knee joint? Okay. So see, unlocking is done by the popliteus. I don't know what they're exactly asking over here. Yeah. But unlocking and locking, there are two activities in the knee joint. Once you hyperextend for some time, the knee joints get locked. Popliteus muscle is used for unlocking of knee joint. Unlocking of knee joint, right? Plantaris is inserted in where? It is inserted in the posterior surface of calcaneum. Yes, because tendon Achilles will form and medial to tendon of calcaneum. It might go over here, so yeah, both can be the answer. What relation of flexor digitum longus is wrong? That's a big, can say a sort of tough question. You see the answer also below, but let us see. What relation of flexor digitum longus? The tendon crosses the tibialis posterior in the lower part of leg. Tendon receives insertion of the flexor digitum accessorius. The forces of tendon gives origin to three lumbrical muscles. Okay. The tendon crosses the tendon of flexor. See, as you'll see the more in the foot part, all these are correct. But why only three lumbrical muscles? There are four lumbrical, why only three? Because why four lumbrical muscles? Okay. Okay. Now let us see another topic, and that is the sole of foot. Sole of foot over here. Now, the sole of foot is similar to that of palm. That is the first line that they're making. That's quite important. It has skin, superficial fascia, deep fascia, and 4 layers of muscles. Nowadays, the sole of foot muscles have started to being asked in the foot, sole of foot. It's quite a different structure. See, your sole of foot, then your what we say the palm of the hand and your scalp. These regions of the body, their skin is a bit different. You'll see more. So here you see the difference between the area of solar foot and the other region of the, say, the lower limb. If you compare the anatomy of the solar foot with the other area of the lower limb, the differences are there. To begin with, in the solar foot, superficial fascia is fibrous and dense, thickened bands of superficial fascia is stretchable. This is, you're not going to see it anywhere else in the skin of the lower limb. You can in fact touch the sole, you understand how different it is from the rest of the skin of the lower limb. Deep fascia is specialized to form the plantar epineuritis, like we had a palmar epineuritis. Initially, in the first line, they have said the structure of sole is similar to that of palm. They have said that in the beginning only. So deep fascia forms plantar epineuritis. It forms these deep transmetatarsal ligaments and fibrous flexor sheath, similar to those in the upper limb as well, in the palm of the hand as well. Right? This is this triangular area. This is your plantar epineuritis. This is whole your plantar epineuritis, and it also gives rise to some muscles as well. Okay. Fair enough. Plantar epineuritis, a short question might come. Shape is triangular. Apex is where apex was present posteriorly, so around the calcaneus. Medial tuberculocalcaneus. Base was present more anteriorly, so it's divided into 5 processes near the head. Distal vessels and nerve can pass. Slip goes opposite the MTP joints. Superficial, and there are 2 sorts of slips over here. And do remember the plantar epineuritis, the deep fascia covering the sole is thick in the center and thin at the sides. Okay. Thickened central part is the one that is known as plantar epineuritis. So if you tell its shape, where is the apex, where is the base? Now, why is this important clinically also? I'm sure some of you might have heard of people saying that, okay, when they walk, there's immense pain in the sole of foot, only in the sole of foot. Okay, so that is what is known as plantar fasciitis. It is quite common. Let me tell you, it is not an uncommon thing. It is quite common. Plantar fasciitis is a disease. Their typical history really, once they wake up from bed in the morning, when they put their foot on the ground, suppose there are no footwear is missing from side of the bed, so they have to walk barefoot. Once they put their foot on the ground, they feel intense pain. Okay, that is sort of plantar fasciitis. You do remember that it has 2 slips over here, and you can go through that. So we should deep slip, a bit of detail over here, and there obviously is going to be a vertical septa, lateral, medial, and transverse vertical septa also there. It arises from the margins. Functions of plantar epineuritis, that is in fact more important. Fixes the skin of sole. You are going to walk and run on the sole of the foot skin, so skin needs to be fixed. Protects deeper structures. Because below in the sole, see, you have the arteries and nerves running in the sole of foot. And suppose you are walking on the foot, aren't those arteries, veins, the vessels will be compressed? Obviously, they will be. This is actually protecting them. It is also forming the arches of foot. Arches of foot are a masterpiece, or masterpiece sort of anatomy over there. All the time they are arched like this, they are concave like this, even though the weight of the body is falling at the top of them. Gives origin to the muscles of the first layer of sole. Okay, that will see. See, plantar fasciitis, as I told, a cousin policeman who stand for long due to stretching of plantar epineuritis results in pain in heel lesions, especially during standing. And main, once they wake up and they put their foot on the ground first thing in the morning, they feel intense pain. Okay, so this was plantar epineuritis, plantar fasciitis, quite a common thing. Muscles of the first layer of sole. Okay, so there are how many layers? 4 layers. How to divide them? See, imagine these are the, say, just imagine these are the bones of the foot. Okay, and this is the skin part. This is the skin part. When you talk of muscles, the first layer will be close to the skin. Then there will be going to be second layer, then going to third layer, then going to be fourth layer. So first layer is at the close to the skin, or it is more superficially first layer. Okay, this is how the 4 layers are divided. First layer is how many muscles? These are 3 muscles of the first layer: abductor digiti, abductor hallucis, and flexor digitum brevis. How to remember them? If you look at the camera, you can look at my image. See, I'm moving my hand like this. Imagine this is the sole of foot, that is these are the toes. This is a great toe, that is a little toe. Once you do action like this, you are abducting your great toe, abducting the little toe, and you are flexing the digits. Abductor hallucis, abductor digiti minimi, and flexor digitorum brevis. By this action, you can remember the first layer of sole muscles. Simple as that. Okay. First layer, all of these muscles. No need to go to details of where do they take origin insertion, but a bit of innervation is what I will advise you. So at least minimum after muscles go through the innervation at least. Action, actually, the name itself is self-explanatory, but actually go to at least the innervation. That was our first layer, three muscles over here. Okay, now second layer, what happens is second layer, we basically have two muscles. So here, basically, to begin with, second layer will have two tendons. Which tendons will be there in the sole? Will there be flexor or extensor tendons? Pause and think for a few seconds. In the sole of foot, will there be flexor tendons or extensor? There are going to be flexor tendons. So you have flexor digitorum longus and flexor hallucis longus. Now what happens is flexor, these are tendons, not muscles. Flexor digitorum longus, its axis is a bit oblique. To straighten it, the muscle number one we have in the second layer is your quadratus plantae. It corrects for oblique pull. You can see it is written over here, quadratus plantae. I told you innervation and action, you can go through it. And the second muscle are the lumbricals. Lumbricals, they take origin from the tendon of the FDL. Okay, they take origin. These are two muscles which are present in the case of your second layer. So one is quadratus plantae, one is lumbricals. They're coming from the tendons of FDL basically. Now comes the third layer. Thirdly, how to remember flexor this, adductor this, flexor this. Again, look at the screen. This is number 3 over here, right? While making 3, I'm flexing my great toe, I'm flexing my little finger. Can you see the names? Flexor hallucis and flexor digiti minimi. And if you can just imagine that, okay, thumb is going or the great toe is going medially adducting, you can remember it as adductor hallucis also. Okay. Else it becomes a bit hard, but remember this. The first layer is this. Second layer, remember, 2 means 2 tendons, FDL. In FDL, you have 2 muscles which are attached to FDL. One is the quadratus plantae, which will straighten the axis, and one is the lumbricals. Okay. Third layer, remember this. Both the flexors and for the thumb, you have an adductor. Both not the thumb, but the great toe, right? Then comes the fourth. The fourth layer, as we discussed, it is most close to the bone now. So you will have intraossei muscles over here, intraossei. And then you can have tendons of these muscles. These are not the muscles, but they're tendons. These are muscles of the lateral and the posterior compartment. So they're tendons you will see close to the bone because the muscles are now inserting onto the tarsals. So their tendons will come over here. Okay. So remember them, innervation and action is one thing that you can go through it, right? So all these images are there. Just look at the images. See which layer could be this flexor. This is longer. This is second layer. Okay, this is second layer, right? Then if you look over here, you have the flexor digiti minimi, flexor hallucis, and adductor. This is the third layer. Okay. If you look at the intraossei, this is going to be the fourth layer with the tendons of tibialis posterior and peroneus longus. These both are having tendons. Muscle is intraossei. Muscles are intraossei. Right? These are again the sole of foot. Clinical anatomy, there are a lot of things. Even you have what we know, all them as specialized group of doctors. They're known as podiatrists. Okay, the foot doctors. There's so many problems in the foot nowadays. Even after so many footwears, there's so many problems in the foot. Apart from having March fracture, there's right from congenital like CTE, congenital talipes, equinus, varus talipes, varus talipes, valgus. So many problems can there in the foot. Even you have the flat foot, which is so much common. 1 to 2% people 1 to 2% people means out of 100, 1 or 2 will have flat foot, also known as pes planus. Flat foot is when the arches are lost. It is seen more as a clinical anatomy of the arches of foot. Okay. Okay. Muscles of the first, let us see some questions over here. Muscles of the first layer of sole are all except remember this. Abductor, and flexor digitorum. So abductor, flexor. Obviously, this will not be in the first layer of sole, which is not inserted into the plantar aspect of foot. Flexor hallucis, peroneus longus, peroneus tertius goes into the lateral side. Inserts basically into the fifth metatarsal and a bit of cuboid bone, not into the plantar aspect. In a movement of what? In a movement of eversion of foot, this movement, all the following muscles are involved except. So basically, eversion is done by all these peroneals. Tibialis will not do uh, in eversion; it does in inversion. Therefore, uh, answer will be tibialis anterior. This will be the answer because it does what? It does inversion. INV dot inversion. The bone devoid of muscle attachment. That is a good question. Talus is the bone. Talus is the one of the tarsals that has no muscle attachment. And what it has a lot of ligamentous attachment. It has a lot of ligamentous attachment. The talus over there. Okay. Remember these points. Next, we go to the popliteal fossa. So popliteal fossa again important topic like cubital fossa. So boundaries, roof, floor, content, all of this is important topic. So let's go through this. This is remember a high topic over here, right? So it is a diamond shaped structure. Structure appears like this. So you have to retract the muscles to look at the popliteal fossa. Normally, it is not like a diamond shape. It is sort of hidden, but you have to retract the muscles to look at the shape. Location behind the knee joint, right? Boundaries above you have what? Above you have the one side will biceps femoris, one side semitendinosus, and lower side you have the gastrocnemius muscles. These are the boundaries. Remember, boundaries might be asked. Roof will have the superficial fascia and the skin. So superficial fascia will have superficial veins and cutaneous nerves. Okay, superficial veins and cutaneous nerves are over here. Floor obviously will have the capsule of the knee joint and the bones around that part. The capsule of the knee joint, the bone, and the popliteal ligaments. This look at this muscle, popliteal muscle. As we discussed, it is having an intracapsular tendon. Popliteal fossa questions do come. Yeah, you should know how to draw this diagram. Practice this diagram, guys. Okay, contents also you have to show the popliteal vein, popliteal artery is deepest than vein. Then above you have this nerve. Okay, it's coming down as a tibial nerve. So that is the main content apart from fat and fascia. Contents artery, vein, and nerve. Nerve, you have the tibial nerve. Also, lately, you will also see the conperoneal and some cutaneous nerves. Lymph nodes will be there in the fat and all that. Fascia will be there. Remember the relation of the artery, vein, and the nerve. Remember, artery basically is most deep, and you have to actually palpate this artery. You need to palpate this artery at times. So, how will you ask the patient? What should be the attitude of the knee joint? Should it be extended or flexed? It should be partially flexed so that this popliteal fossa area is now loose so that you can do a deep palpation. If the knee is extended, the legs are straight, then the popliteal fossa area becomes quite stiff. You can't do a deep palpation. Just remember that how to palpate it. That is also quite important, right? Popliteal artery, we all are aware of already, or it's that is continuation of the femoral artery. Okay, it begins where the femoral artery ends and it goes down, terminates into two tibial arteries that we already have done. Anterior popliteal artery and the relations are anterior deep to the artery. Okay, so anterior relation will be deep to the artery. So these are the popliteal fossa contents. Posterior the tibial nerve. Laterally we have these structures and medially. So remember these popliteal artery relations are also not that infrequently asked. They can be asked because popliteal artery itself is quite important artery, and as a surgery, you might be encountering this area. Okay, diagram should know. Explain about branches. So branches in the arteries always go through the muscular branches, artery, cutaneous, and the joint. That is very important. Genicular means joint. So it supplies a lot of genicular branches over here. Middle genicular branch, this might be asked separately. It's important. Middle genicular, read it. It pierces this ligament and enters inside the knee joint. Middle genicular branch, right? That is important in the case of popliteal artery. Clinical anatomy, needless to say, is the most important aspect of whatever anatomy you read. So you can see BP measured can also be measured. Also known as the ankle brachial index is what you also see in examination of medicine, right? Ankle brachial. Brachial means we normally measure BP over here. We can also measure BP in the lower limb. Look at the changes if there are any. Popliteal artery can be occluded, can be get thrombus, they can be atherosclerosis, they can be aneurysms. But these popliteal artery problems which are discussed over here, nowadays they are less frequently seen. Earlier, like 100 to 200 years back, due to horse riding, when you wear all those high boots and all, and you're riding on a horse, those high boots, their upper edges, they always strike at the level of popliteal fossa. That could lead to popliteal artery and popliteal vein issues. But nowadays, because really people wear high boots, even if they wear, they are not sitting on the horse on a regular basis. Only few people, you can, obviously that very few people are riding horses sitting like this with half boots on. Okay. Same goes to the popliteal vein and continues as the femoral vein. Tributary is just, remember these tributaries over here, the small saphenous vein, right? So it becomes important case of structures. Right, so this was it, guys, from tibial nerve. We'll do in the next session, we'll do the tibial nerve part, right? I hope you guys are enjoying the session, and don't forget to book a slot. Thanks for watching. Any issues, anything you want to ask, add, write in the comment box, right? I'll be more than happy to answer them. So that's all, guys. See you soon, right? Thank you.